Hi and welcome to my updated lecture for abnormal uterine bleeding, and most of the updates here are coming from the 2018 FIGO updates on AUB. References for this lecture are the following: Comprehensive Gynecology 7th edition and the 2018 FIGO update for AUB written by Munro et al. In 2018. To download my lecture deck, please go to my WordPress site, Docina Obigaine. And this is the outline of this lecture. So AUB is one of the most common health concerns of women. It can present in many ways, from infrequent episodes such as oligomenorrhea to excessive flow such as HMB or heavy menstrual bleeding, or prolonged duration of menses and intermenstrual bleeding. However, this lecture will focus only on heavy menstrual bleeding. So in order to understand what AUB means, we have to review first what normal menstrual blood flow is. So the normal menstrual blood flow, mean duration, is about 24 to 38 days with an average menstrual blood loss or MBL of 35 ml with a normal range of 10 to 80 ml. Then the average number of days of menses is about 4 days. The normal is about less than or equal to 8 days. Now, bleeding is considered abnormal if it occurs at intervals of less than 24 days or more than 38 days, it lasts longer than 8 days, or there's a menstrual blood loss of 80 ml or greater. Now, the term DUB or dysfunctional uterine bleeding is no longer favored and should be discarded. Now, as for the FIGO 2018 update, we define heavy menstrual bleeding or HMB as excessive menstrual blood loss which interfere with the woman's physical, social, emotional, and or material quality of life. And these are the updated definitions of acute and chronic AUB. So, chronic AUB in the reproductive years is defined as bleeding from the uterine corpus that is abnormal in duration, volume, frequency, and or regularity, and has been present for the majority of the preceding 6 months. So the important words here will be 6 months. So for acute AUB, this is defined as an episode of heavy bleeding that, in the opinion of the clinician, is of sufficient quantity to require immediate intervention to minimize or prevent further blood loss. So for acute AUB, this is heavy menstrual bleeding that requires immediate intervention. Acute heavy menstrual bleeding may present in the context of existing chronic AUB or can occur in the absence of such a background history. Now, this is what we call the FIGO AUB System 1. So, written here are the revision of terminologies and definitions of symptoms of abnormal uterine bleeding. So, for the FIGO 2018 update for the FIGO AUB System 1, so for under the frequency, amenorrhea is now part of this category. Okay, so for regularity, we already refined the definition of regularity. Normal variation from the shortest to longest will be 7 to 9 days with slight variance depending on the age. For duration, we only have 2 categories now. So we have normal, which is less than or equal to 8 days, and prolonged, which is more than 8 days. Now for the volume, we have the light, normal, and heavy, and the definition of volume will be according to the definition by the NICE, and this is bleeding that's sufficient to interfere with the woman's quality of life. Okay, now we also include the term intermenstrual bleeding. Okay, so this is spontaneous bleeding that occurs between menstrual periods, and it can be either cyclical or random. Now, this is the FIGO AUB System 2. Okay, so this is better known as the palm coin classification of the causes of AUB. So, palm stands for polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia. And the palm are the anatomic causes of AUB. We also have the coin part, which stands for coagulopathy, ovulatory dysfunction, endometrial causes, iatrogenic, and not otherwise classified, and these are the non-anatomic causes of AUB. Now, for the diagnosis notation, the acronym AUB will be followed by the letters palm coin and a subscript of 0 or 1 associated with each letter to indicate the absence or presence respectively of the abnormality. So, a subscript of 1 means that there is abnormality, and a subscript of 0 means the absence of the abnormality. So, for example, we have a patient with abnormal uterine bleeding due to a polyp. So, we denote that as AUB palm coin and place a subscript for P, and then place a subscript of 0 for the rest of the letters. Now, in reality or in clinical practice, it may be a bit cumbersome to write this whole very long diagnosis notation. So, in place of this very long notation, we can do an abbreviated form of notation. So, instead of placing a subscript of 1 and 0 for the palm coin, we can just write AUB-P. Okay, so what about if the patient has multiple etiologies, such as in this case? So we have a patient with abnormal uterine bleeding that is both irregular and heavy and may have endometrial hyperplasia and anovulation. So obviously, we have two etiologies here. Anovulation, which will be under O, and endometrial hyperplasia, which will be under M. So that's AUB palm coin with a subscript of 1 for M and a subscript of 1 for O and a subscript of 0 for all the other letters. Okay, so if you want the abbreviated notation, then you can just simply write AUB-M-O. Okay, this is what we call the FIGO AUB System 2 diagnostic matrix. Okay, so as you can see here, this matrix consists of the columns for the etiology of the AUB, that's a palm coin, column for yes, column for no, and a column for the question mark. So how do we do this now? So for example, if the patient is not yet fully evaluated for a specific etiology, then we place an X mark across or under the question mark column across that specific etiology. Okay, so for example, if the patient was fully worked up and a specific etiology was determined, then we place an X mark under the Y column across that specific etiology. So for example, in this case, we have a patient whose bleeding is secondary to a leiomyoma. So we place an X across L under the Y column. Now, we place an X under the N column across that specific etiology when we're very sure that we've already ruled out this specific etiology using appropriate diagnostic workups. Okay, for this example here, we have a patient whose abnormal uterine bleeding is secondary to a leiomyoma and endometrial pathology. Okay, so now let us discuss the pathophysiology of abnormal uterine bleeding, and as we've already mentioned, we use the palm coin classification. Okay, so first letter P. So P stands for endometrial polyps or AUB-P. These are localized overgrowths of endometrial tissue containing glands, stroma, and blood vessels covered with epithelium, and these are mostly commonly found among reproductive age women. Estrogen stimulation is thought to play a key role in this development. These are usually benign tumors, and women with symptomatic polyps can be treated safely and effectively using operative hysteroscopy. Next is letter A, and this stands for adenomyosis or AUB-A. The presence of endometrial glands and stroma in the uterine myometrium is pathognomonic for adenomyosis, and these are ectopic endometrial tissue that leads to hypertrophy of the surrounding myometrium. Risk factors include multiparity, which is the most significant risk factor, and any process that allows for penetration of endometrial glands and stroma past the basalis layer. So this can include dilatation and curettage, cesarean delivery, and spontaneous abortion. A finding on ultrasound of an enlarged asymmetric uterus is the usual or the common finding among women with adenomyosis. Abnormal uterine bleeding due to adenomyosis is thought to be a result of altered uterine contractility and is associated with profound dysmenorrhea. And these are the diagnostic criteria that is important for us to diagnose adenomyosis using ultrasound. And listed here are 8 criteria. So we have asymmetrical myometrial thickening, myometrial cyst, hyperechoic islands, fan-shaped shadowing, echogenic subendometrial lines and buds, translesional vascularity where present, irregular junctional zone, and interrupted junctional zone. So we just have to fulfill at least 2 of the criteria to be able to ultrasonographically diagnose adenomyosis. L stands for leiomyoma. So leiomyoma is also called fibroids, and these are benign tumors of the uterine myometrium. The pathogenesis includes myometrial injury, leading to cellular proliferation, decreased apoptosis, increased production of extracellular matrix, and overexpression of transforming growth factor beta that leads to fibrosis of these tumors. The mechanisms by which fibroids cause abnormal uterine bleeding depend mainly on the size, the location, and the number of leiomyoma. So basically, we have 3 types of leiomyoma. We have the submucous type, intramural, and the subserous fibroids. And it's actually the submucous fibroids that are usually implicated in abnormal uterine bleeding. Okay, so as for the management of leiomyoma, we can either offer medical or surgical management. Now, this is what we call the FIGO Leiomyoma subclassification system. So, as you can see here, we have 8 subclassification of leiomyoma. Type 0, type 1, and type 2 are the submucous types. So, type 0 will be the intracavitary or the purely intracavitary submucous myoma. Type 1 will be a submucous myoma with less than 50% intramural component. Type 2 is a submucous myoma with a greater than 50% intramural component. Type 3 is actually 100% intramural. However, part of this intramural myoma contacts endometrium, and that's why it can cause or possibly cause abnormal uterine bleeding. So that's type 3. Type 4 is intramural. Type 5 is subserous with greater than 50% intramural component. Type 6 is subserous myoma with a less than 50% intramural component. So, type 7 is subserous, that's pedunculated. And type 8 are the other types of leiomyoma, could be cervical leiomyoma or the parasitic leiomyoma. Okay, M stands for malignancy or AUB-M. And the types of malignancy that can cause AUB are the following: vulvar, vaginal, cervical, endometrial, uterine, and adnexal cancers. Bleeding from cervical malignancy classically presents as postcoital bleeding or intermenstrual bleeding. Endometrial cancer is mostly secondary to prolonged exposure to a hyperestrogenic state. An example of this would be chronic anovulation, PCOS, obesity, newly gravidity. The Lynch syndrome or hereditary non-polyposis colorectal cancer is an autosomal dominant disease that is caused by a disruption in the mismatch repair genes. Okay, so this carries a 40 to 50% lifetime risk of endometrial cancer, mostly before the age of 45 years old. Also, there are estrogen-producing ovarian tumors such as the granulosa theca cell tumors that can cause AUB. C stands for coagulopathy or AUBC. Disorders of blood coagulation such as von Willebrand disease, which is the most common, prothrombin deficiency, hemophilia, leukemia, severe sepsis, idiopathic thrombocytopenic purpura, and hypersplenism are under this category. So routine screening mainly indicated for the adolescent who has prolonged heavy menses beginning at menarche. In adults, screening is indicated by clinical signs such as bleeding gums, epistaxis, or ecchymosis. Now, previously, prior to the FIGO 2018 update, the use of chronic anticoagulation such as heparin and the like are under this category. So now, after the 2018 FIGO update, the use of chronic anticoagulation such as heparin, low molecular weight heparin, direct thrombin inhibitors, and direct factor XA inhibitors are no longer under this category. So this is a diagnostic approach to adults with abnormal uterine bleeding due to coagulopathy. So if the adult is exhibiting HMB and she has a history of either one of the following, such as a postpartum hemorrhage, surgical bleed or dental bleed, or two of the following: bruising that's greater than 5 centimeters, epistaxis of 1 to 2 times a month, gum bleeding, or a family history of bleeding, then you test her using these diagnostics. Okay, so you can request for CBC with platelet count, PT-PTT, von Willebrand factor antigen, and restaucitin cofactor. Now, this is just another representation of the algorithm that was presented from the previous slide. And this is a screening instrument for coagulopathies in women with the symptom of heavy menstrual bleeding. Essentially, it just contains what we have already discussed from the previous slide. Okay, so O stands for ovulatory dysfunction, or AUB-O. Okay, so anovulatory bleeding is most common during the extremes of reproductive life. So in the first few years after menarche and during perimenopause. In the adolescent, anovulation is mainly due to an immature HPO axis and the failure of positive feedback of estradiol to cause a luteinizing hormone surge. In the perimenopausal woman, anovulation is mainly due to the lack of synchronization between the components of the HPO axis as the woman approaches ovarian decline at menopause. The predominant cause of ovulatory dysfunction post-menarcheal and premenopausal women is secondary to alterations in neuroendocrine function. Now, there is continuous estradiol production without corpus luteum formation and progesterone production. So there's a continuous proliferating endometrium which may outgrow its blood supply and therefore lead to necrosis. Now, uniform slough to the basalis layer does not occur, which produces excessive uterine bleeding. The patterns of anovulatory bleeding may be oligomenorrhea, intermenstrual bleeding, or heavy menstrual bleeding. Now, what are the causes of anovulation? It can be extremes of reproductive life, as I've already mentioned in the previous slides. It can be PCOS, hypothalamic dysfunction such as related to weight loss, severe exercise, stress, or drug use, or abnormalities of other non-reproductive hormones such as thyroid hormone, prolactin, and cortisol. I stands for iatrogenic, or AUB-I, and this is abnormal uterine bleeding resulting from medications. Most common of these medications will be hormonal preparations, including selective estrogen receptor modulators, gonadotropic releasing hormone agonists and antagonists, and even contraceptives. Okay, so hyperprolactinemia can result from central nervous system dopamine antagonism of certain antipsychotic drugs, for example, risperidone, and combined and progesterone-only contraceptives may result also in breakthrough bleeding. Interactions between oral contraceptives and other medications, such as antibiotics and anticonvulsants, may alter circulating levels of steroids, allowing follicular recruitment and increased endogenous levels of estrogen. And as I've already mentioned, the use of chronic anticoagulation such as heparin, low molecular weight heparin, direct thrombin inhibitors, and direct factor 10A inhibitors are no longer under AUBC, but it is now, after the FIGO 2018 update, it is now under the category AUB-I. So please remember that. Okay, E stands for endometrial, or AUB-E. This is heavy menstrual bleeding in the absence of other abnormalities that are thought to have underlying disorders of the endometrium or are otherwise unclassified. In the past, this category has been called DUB. Okay, so the primary line of defense to excessive bleeding during normal menses, as you already know, is the formation of the platelet plug, followed by uterine contractility mediated by PGF2 alpha. Thus, prolonged and heavy bleeding can occur with abnormalities of the platelet plug or inadequate uterine levels of the PGF2 alpha. In some women with heavy menstrual bleeding, there is excessive uterine production of prostacyclin, which is a vasodilatory prostaglandin that opposes platelet adhesion and may also interfere with uterine contractility. Deficiency of uterine PGF2 alpha or excessive production of PGE, which is a vasodilatory prostaglandin, may also explain ovulatory DUB. A low PGF2 alpha PGE ratio will increase menstrual blood loss. Now, N is not otherwise classified, or AUB-N. This is abnormal uterine bleeding that is not classified in the previous categories. Examples under this category will be foreign bodies or trauma. Now, as per the 2018 FIGO update, a new example under this category will be a niche or ismosil associated with previous CS. And these are the summary of changes to the FIGO AUB System 2 causes or the contributors to AUB in the reproductive years. So as I've already mentioned, AUB-A, we already used the 8 diagnostic ultrasonographic criteria. For AUB-L, there's the inclusion of the type 3 as a submucous leiomyoma. That's a 100% intramural myoma but with a contact with the endometrium. AUB-C, again, no longer includes pharmacologic agents that impair blood coagulation. Instead, we already categorize that under AUB-I. Okay, so again, just to emphasize, AUB-I now includes AUB associated with pharmacologic agents. Okay, so AUB-O no longer includes ovulatory disorders associated with drugs known or suspected to interfere in ovulation, such as NSAIDs. Instead, those drugs will be under AUB-I. And lastly, AUB-N, the name of the category has been changed from, previously we called it not yet classified, now we call it not otherwise classified. And of course, as I've already mentioned, we now include the example of ismosil following lower uterine segment cesarean section under this category. Alright, so here are some of the examples of the use of a matrix to guide FIGO-based evaluation of patients with chronic AUB. So we can see here we use the System 1, System 2, and this matrix. Okay, so for System 1, for example, we have a cycle length of 30 days for this patient, regularity of about 2 days, duration of 10 days. She has heavy menstrual bleeding and intermenstrual bleeding. So on workup, on ultrasound, she has leiomyoma type 2. Okay, so what do we do now with the matrix? We place an X under the Y column across L and place an X under the N column for all the other letters. Okay, so next example, we have this patient with a cycle length of 14 to 60 days under System 1. So regularity of about 46 days. So you can see that this is a highly irregular menses. A duration of 2 to 11 days. Volume of normal to heavy with intermenstrual bleeding. So obviously, she has an ovulatory disorder. And on workup, she has a type 6 leiomyoma. So we place an X under the Y column for across L and O, and place an X under the N column for all the other letters. So likewise, for this patient, under System 1, she has a cycle length of 31 days, regularity of about 3 days, duration of 4 days, normal volume, but with intermenstrual bleeding. And on workup, she was found to have a polyp, an endometrial polyp, and a leiomyoma. So for this matrix, we place an X under the Y column across P and L, and place an X under the N column across all the other letters. Okay, so the diagnosis for this patient is AUB-P-L. So let us now discuss a diagnostic approach for AUB. Of course, the first thing to do here would be to do a thorough history and physical exam and supplement this with important laboratory exams. Okay, so for the medical history, we ask her for her menstrual history, inquire whether and when the menstrual pattern changed, describe the menstrual abnormality, and we encourage also our patients to use a menstrual calendar to record her bleeding episodes. And this, again, I'm showing you now, again, the screening instrument that we can use to screen for coagulopathies in women with the symptom of heavy menstrual bleeding. So it will help us a lot if you ask her about these signs and symptoms. For all patients, we ask the age at menarche, cycle length, duration of bleeding, perception of flow, menstrual product use, the first day of her last menses, and if there is any dysmenorrhea noted. And this is an example of the menstrual calendar that we can offer our patients and will be very helpful for us to evaluate her heavy menstrual bleeding. Now, these are some of the clues that we can elicit to determine if the patient has heavy menstrual bleeding. So if her menses are lasting for more than 7 days, soaking through pads or tampons in 1 hour for 2 to 3 hours in a row, when she requires frequent tampon or pad changes, when she's passing blood clots that's more than an inch in diameter, when she's using double protection, when she's experiencing flooding or gushing sensation, frequent accidents or leaking through protection, when she has a hemorrhage from a corpus luteum, when she's diagnosed already with anemia, and if her heavy menstrual bleeding is associated with history of excessive bruising or bleeding or a family history of bleeding disorder. Also ask her about her social history. Are there any social stressors? Is she using illicit drugs? And ask her also about her exercise patterns and whether or not she's engaged with athletic competition. Ask her also about her family history of bleeding disorders, diabetes, thyroid disorders. Past medical history will include systemic illnesses, including hematologic or renal diseases, and current or recent medications. Of course, ask her about her sexual history, especially the use of contraception, her number of previous partners or current partners, history of sexually transmitted infections, previous pregnancy or abortion, and the history of sexual abuse or assault. For the physical exam, of course, it is very important that we determine her vital signs, because tachycardia and hypotension may signal acute hemodynamic instability and the need for rapid intervention. The presence of tachycardia, pallor, or a heart murmur may suggest anemia also. Note also for the presence of petechiae or excessive bruising, which may suggest platelet defect or another bleeding disorder. Obesity, acne, hirsutism, and acanthosis nigricans may be present in the patient with PCOS. Palpate for the thyroid gland for any abnormalities or enlargement. Examine the optic fundi and do visual field testing. Determine sexual maturity rating of the breast and assess for galactorrhea. And of course, palpate the abdomen. Of course, don't forget to do a thorough examination of the genitalia and the reproductive organs. For the laboratory evaluation, of course, it's very, very important to first rule out pregnancy. Of course, this is AUB in a reproductive age woman. We have to first rule out pregnancy by requesting for a pregnancy test, of course. Also request for complete blood count, including differential and platelet count, blood typing, iron stores, prothrombin time, and activated partial thromboplastin time. We also request for von Willebrand studies, von Willebrand factor antigen, factor 8, ristocetin cofactor, especially if our patient is of pediatric age. We can also request for TSH. We can also test for chlamydia trachomatis and Neisseria gonorrhea, especially when we see some infection on pelvic exam. And of course, do pelvic ultrasound. Now, if your patient has a history of amenorrhea or irregular bleeding prior to the onset of heavy bleeding, then you could request for the following: FSH and LH, testosterone levels, dihydroepiandrosterone, and prolactin levels. Now we discuss the treatment of AUB. The management of AUB depends on assessment of whether or not the patient is hemodynamically stable, determination of the underlying cause, and medical management based on etiology and severity of anemia. The goals of treatment are the following: to establish and or maintain hemodynamic stability, to correct acute or chronic anemia, to return to a pattern of normal menstrual cycles, to prevent recurrence, and to prevent long-term consequences of anovulation. The goal of medical therapy is to stabilize the endometrium with estrogen that will provide initial hemostasis followed by progestins for endometrial stability. Typically, this is achieved by the use of combined oral contraceptives. Episodes of moderate to severe bleeding can typically be treated effectively with frequent dosing of combined oral contraceptives. Now, how do we manage abnormal uterine bleeding secondary to ovulatory dysfunction? Okay, for the adolescents, after ruling out coagulation disorders, which is a very important step, the main direction of therapy, of course, is to temporize now, because once the HPO axis matures, then the problem will be corrected. Then what can we give for these adolescents? We can give cyclic progestogen or oral contraceptives. For the perimenopausal woman, we can give low-dose combined oral contraceptives or cyclic progestogens. For the reproductive age women, we can give combined oral contraceptives or cyclic progestogens also. Now for AUB-E, these are for women with heavy menstrual bleeding for whom there is no known cause and anatomic lesions have been ruled out. The aim of therapy is to reduce the amount of excessive bleeding. Okay, so some women with AUB-E have abnormal prostaglandin production and some have alterations of endometrial blood flow. Now, the options for treatment will include the following. We can give progestogens, oral contraceptive pills, or insert an LNG IUS or a levonorgestrel intrauterine system. Can we give NSAIDs? Of course, we can give NSAIDs. This is part of our armamentarium. And prostaglandin synthetase inhibitors that inhibit the biosynthesis of the cyclic endoperoxides which convert arachidonic acid to prostaglandins. This block the action of prostaglandins by interfering directly at the receptor sites. Now, all NSAIDs are cyclooxygenase inhibitors and thus block the formation of both thromboxane and prostacyclin pathway. So, nevertheless, NSAIDs have been shown to reduce menstrual blood loss, primarily in women who ovulate. So, what can we give? Here are some of the examples. We can give mefenamic acid 500 milligrams 3 times a day, ibuprofen 400 milligrams 3 times a day, or naproxen sodium 275 milligrams every 6 hours after a loading dose of 550 milligrams. Now, this NSAIDs should be given in the first 3 days of menses or the whole duration of the bleeding. We can also give antifibrinolytic agents, okay, in the form of aminocaproic acid, tranexamic acid, and para-aminomethylbenzoic acid, which are potent inhibitors of fibrinolysis. However, their use is somewhat limited by their side effects, and these are mainly GI side effects, and can be minimized by reducing the dose and limiting the therapy to the first 3 to 5 days of bleeding. Okay? Now, due to the increased risk of thrombosis and myocardial infarction, antifibrinolytic agents should not be combined with oral contraceptives. Combined treatment with tranexamic acid and oral contraceptives have been implicated in coronary ulcerated plaque and acute myocardial infarction. So, it's a big no-no to simultaneously give antifibrinolytic agents with oral contraceptives. We can also give gonadotropin-releasing hormone agonist, and this may be used to inhibit ovarian steroid production as estrogen production is necessary for endometrial proliferation. However, because of the expense and the menopausal side effects of these agents, their use is limited to women with severe menstrual blood loss who fail to respond to other methods of medical management and wish to retain their childbearing capacity. More commonly, GnRH agonists are an effective means of bridging patients to surgical treatment, allowing for correction of anemia. The use of an estrogen or progestogen add-back therapy together with the agonist will help prevent bone loss. Now, how do we manage acute uterine bleeding? In women who are bleeding heavily and are hemodynamically unstable, the quickest way to stop acute bleeding is with curettage. Curettage should also be the preferred approach for older women and those with medical risk factors for whom high-dose hormonal therapy may pose a great risk. To stop acute bleeding that does not require curettage, the most effective regimen involves high-dose estrogen. High-dose estrogen is aimed at stopping acute bleeding and is merely a temporary measure. Estrogen in pharmacologic doses causes rapid growth of the endometrium. A rapid growth of the endometrial tissue occurs over the denuded and raw epithelial surfaces. Now, how do we give estrogen? What are the regimens available? We can give oral conjugated equine estrogen 10 milligrams a day in 4 divided doses. We can also give it through IV, but 25 milligrams Q4 to Q6 hours until the bleeding stops, but no more than 6 doses should be administered. Or we can also give combination oral contraceptives, okay? So that contains both estrogen and progestin. So that's 4 tablets of an oral contraceptive containing 30 to 35 micrograms of estrogen taken every 24 hours in divided doses. You can also give progestogens. These are indicated for patients with contraindication to estrogen. such as those with prior thrombosis, those with certain rheumatologic diseases, or estrogen-responsive cancers. Progestogens not only stop endometrial growth, but they also support and organize the endometrium so that an organized slough occurs after their withdrawal. With progestogen treatment, an organized slough to the basalis layer allows a rapid cessation of bleeding. And what are the regimens that we can give? We can give medroxyprogesterone acetate. We can also give depo-MPA, 150 milligrams intramuscularly, and we can give norethindrone acetate. We can also give androgens in the form of danazol. And danazol is a synthetic androgen that is used in doses of 200 milligrams daily for the treatment of heavy menstrual bleeding. However, limited use for androgens. There is limited use for androgens because of the side effects of weight gain and skin problems, and also effect on the lipid profile. Now, what are the indications for hospitalization? Of course, when the patient is hemodynamically unstable, when her hemoglobin concentration is less than 7, or if it's less than 10, if with active heavy bleeding, if she has symptomatic anemia, if there's a need for intravenous conjugated estrogen, and if there's a need for surgical intervention. Now, we discussed the surgical management of acute AUB. Okay, we can do endometrial biopsy, and we perform endometrial biopsy for these indications when the patient is more than 40 years old, with risk factors for endometrial cancer such as obesity, hypertension, diabetes, PCOS, or a strong family history of hereditary non-polyposis colorectal cancer. When there's failure of medical management, when there's significant intermenstrual bleeding, or infrequent menses suggestive of anovulatory cycles. We can also do dilatation and curettage, and this is both diagnostic and therapeutic for the immediate management of severe bleeding. These are indicated for women with markedly excessive uterine bleeding who may be hypovolemic. Okay, so DNC is the quickest way to stop acute bleeding. And DNC may be preferred as an approach to stop acute bleeding episode in women older than 35 when the incidence of pathologic findings increases. Another choice would be endometrial ablation. Now, this is an option if medical therapy is not effective or is contraindicated. Exceptions are women who have very large uteri caused by fibroids or abnormal pathology such as endometrial hyperplasia or cancer. And this is a good alternative to hysterectomy. And the last surgical option will be hysterectomy, and this is the surgical removal of the uterus. This is reserved only for women with other indications for hysterectomy such as leiomyoma or uterine prolapse. This is offered only for women with completed family size or those women who no longer are desirous of pregnancy. And this is used to treat persistent AUB after all medical therapy has failed or medical therapy is contraindicated. And lastly, these are the treatment options that we can give for patients with chronic AUB. So we can offer insertion of an LNG-IUS or levonorgestrel intrauterine system, oral contraceptives, progestin therapy, tranexamic acid, NSAIDs, and GnRH agonist. So that's it for my lecture. Thank you for watching. And please don't forget to subscribe in my YouTube channel and my WordPress site, Doc Ina Obigaine. Thank you.